I have the honor and the pleasure to be presenting to you, and it's one of the things that I enjoy the most, to talk to patient groups, and I don't get tired of saying this, and I'm not saying this because you're present. This is just the most fun, most involved group of patients and patient advocates that I have the fortune to work with through the years in different capacities. So thank you again for having me. This is a lot of fun. I want to make this not a lecture. I don't like the pedestal. I don't like to be lecturing people and sound boring. So if at any point anybody has any comment to make or has any question, stop me. I know that sometimes we tend to get very technical on how we speak, and so just let me know, stop me and ask me. So again, Dr. Sami asked me today to talk about the retrosigmoid approach, and as I was preparing this, I I reflected a little bit. This is a little bit of a funny story because this is an approach that's mostly a neurosurgical approach, and this is how I learned how to operate on vestibular schwannomas, or acoustic neuromas, as some people refer to. And you know, my training is in neurosurgery, and so what I learned to do was vestibular schwannoma through the retrosigmoid approach, because we didn't need anybody. It was there in the brain, and we took it out through this approach. And then when I came to Cincinnati, I came to this mecca of what was called a skull-base surgery, which was a sexy term back then. And what was this? I mean, this secret code of skull-base surgery was just sitting down with our ENT surgeons, otologists, rhinologists, and trying to figure out different ways on how to best treat the patients, really. And this is where I learned how to do all the other approaches. And if it wasn't because of people like Dr. Sami and Dr. Pensack, who came before him, I would be incomplete as a surgeon. And so I think that the feeling is mutual, and truly everybody brings a little bit of their own philosophy and their own vision and the little tricks of his own specialty together to treat the patients. And I think that has really distinguished us through the years, not only as a center for treating patients, but also as a center for treating people. You should know that nowadays, Dr. Sami's training program in neurotology is one of the highest sought after positions in the world of neurotology. And so I'm very proud of being part of this, a little contributor. And you know, I think that I usually get more than what I give to the program, and that's why I keep on coming back. So a brief introduction on acoustic neuromas or vestibular schwannomas. They're used interchangeably. The proper term is vestibular schwannomas. These are tumors from the Schwann cells, which are the wrappings. It's like the insulating plastic around the wire that the nerves have. They're more common than most people think. We're getting to see a lot of this nowadays, that people are getting MRI for different reasons: a headache, a dizzy spell, a fall, different reasons. And they make up about 90%, 85, 90% of the tumors that we see in the region called the Cerebello-Pontine angle. And I'll show you slides. The cerebellum is this structure here. This is a scan of the head of a person. This is the brainstem. What you see here are parts of the ear. This is the back of the head. And here is the nose that has been a little bit cut here as part of this scan. And so this is the brainstem. And from the brainstem, I'll show you a slide in a second, we have nerves that come out. And this is the vestibular nerve, along with the auditory nerve and the facial nerve. And this is the nerve on the other side with the tumor on it. And we have grossly two different big divisions. And when we look at this, whether they're sporadic, meaning that they're not associated with any genetic condition, versus the neurofibromatosis type 2, which is the NF2. So there's about 1 to 2 per 100,000 persons per year in the United States that get diagnosed with this. Almost about 10% of the tumors that we see at least in the neurosurgical practice, and the big majority of tumors in that cerebellopontine angle. They're unilateral 90% of the cases. Bilateral schwannomas are primarily seen on patients with NF2. They're rare in children, but we see them. We're blessed with having a very strong children's hospital here, where we're part of, and that's where we see a lot of our NF2 patients, because NF2 vestibular schwannomas are, identified earlier in life. So what causes it? This is a question that patients ask me all the time, and it's just, if you don't have NF2, I tell them it's bad luck. We don't have any true information that is reliable or consistently reproducible. There's been studies back in the 90s about the cell phone radiations, exposure to noise, some environmental factors. We really don't have any proof of anything causing this in sporadic patients. For patients with NF2, yes, there is a genetic mutation that makes people prone to developing tumors in the Schwann cells, and for some reason that is still not entirely known, the vestibular nerve or the cranial nerves, facial nerve, they're popular sites. They're tumors where they're areas where NF2 manifests itself more prominently. So I talked about the cerebellopontine angle, and I hope that you're not scared of looking at this picture. So these are specimens of a brainstem seen from the front, and this is the cerebellum, both hemispheres of the cerebellum, and this is the pons. This is the mid part of the brainstem. And so if you look at this in perspective, like if you would look at this from the feet, again, this is that pons, and this is the cerebellum. So there's an angle that you can identify here, and that's the famous cerebellopontine angle. And so why is that area mentioned as cerebellopontine angle is so relevant? Because that's where the nerves take off. And this that has the number 7, we have the cranial nerves with number in neurosurgery or in neurology. And the 7th and the 8th nerve, the 7th is the facial nerve, the 8th nerve is the auditory nerve along with the vestibular nerves. That is the area where you normally see the tumors coming up. So anywhere from the takeoff of this 7-8 complex, because they run together along the pathway into what will be the internal auditory canal, which is the bone that has the nerves and all the hearing apparatus, that's where you may develop a vestibular schwannoma. And that's the cerebellopontine angle. So this is a view, the same type of slice seen on the MRI. So this is the cerebellum here, and this is the pons, and this is the cerebellopontine angle. And this little spaghetti that you see here are the vestibular, facial, and auditory nerves. And what you see here are part of the hearing apparatus. This is the famous cochlea, and these are part of the semicircular canals. And this is the temporal bone, and your ear will be here, okay? So with this introduction, and now we know where these tumors will be found, what are the symptoms? How do they manifest? Well, there's a number of reasons or different ways in how they manifest. Could be because of hearing loss. It will be the more common way of doing it. When the tumor is small, it only affects mostly the auditory nerve. Sometimes they give you some dizziness, and now when they get this big, they not only compress the auditory vestibular nerve, but also they compress the cerebellum and the brainstem, and then you start having symptoms that relate to those structures. And so, and that may be manifested by balance problems, by incoordination, people who have falls. Sometimes if there's significant compression of the pathways that through which the cerebrospinal fluid circulates in the brain, that may be manifested by something called hydrocephalus, which could be a potentially lethal condition. And every once in a while, we find patients that way because they grow so slowly that they don't give you much symptoms. And then until you reach a break point, they become symptomatic. So tumor growth obviously will be a reason for causing symptoms. The clinical presentation, unilateral sensory neural hearing loss. You will see this a lot with poor speech discrimination on your audiograms. It's the big number one symptom. Tinnitus, ringing in your ears, very common. Imbalance, about 10%. Facial numbness is rare, truly. Hardly ever see that. And that's not because of affection of the facial nerve. The facial nerve is mostly a motor nerve, the one that helps you move your face. It's because of compression of the trigeminal nerve, which is a nerve that is a little bit more distant, but usually gives you an idea that this is a large tumor because it has to have traveled a longer distance to compress the facial nerve. And as I said before, a lot of people are getting MRIs for different reasons, and they don't have any symptoms, not even an audiogram finding, and they're incidental. And so those are the ones that we need to watch, and those are the ones where we need to be very careful when we recommend treatment. So the natural history, historically, they're very slow growing tumors. They're benign in the big majority of them, of the cases, 99.9% of the times are benign. They grow very slowly, 1.5 millimeters a year. That is less than a tenth of an inch. It's very small growth rate. Many of these tumors don't grow at all. And some may grow through a brief period of time and then they stop growing. And really, we don't have any data of any environmental or dietary factors. This is a very popular question that we get. Is there anything that I did? No, there's nothing that you did, Mr. Patient. It's just bad luck. We don't know. We cannot predict how these tumors will behave. Malignancy is extremely, extremely, extremely rare. I think that I can count with less than the fingers that I have in one hand how many malignant of these I have seen. How do I diagnose this? With physical exam, obviously. The audiometry is the best test that you can do for screening. And then imaging. Nowadays, MRI is king. That's the very accurate method, can pick up tumors that are very, very, very small. If you cannot have MRI, which is a common situation now with people have implants, pacemakers, you can get a high resolution CAT scan with some contrast, and that may usually help. It's not as precise as the MRI at detecting small tumors, but it will help you. And now we come to the treatment. How do you observe this? Do you recommend radiation? Do you recommend surgery? I think that, having all those options available makes you better prepared to treat with it. But what's the best approach? Is the one that works best for the patient. And how do you decide this? Well, there's several considerations. There are tumor-related considerations. What's the hearing status? Where it's located? The tumor size? What are your anticipated complications or neurologic deficits? Are you going to do this at a single session? Is it this tumor that big that you may have to do more than one surgery? There are factors related to the patient. NF2 patients, does this patient have a bilateral tumor? So then that will affect your strategy. How sick, how healthy is your patient? Are there any other neurologic deficits? What are the patient expectations? I always talk about the patients with vestibular schwannoma, that they're the most educated patients, because before they have come to your office, they have done all their homework, the research, and you're usually not always the first neurosurgeons that they will have seen. I will never forget when I was training and I was working with Dr. Tu, which was one of the top surgeons in the country at the time, a patient that came with a stack of paper like this. And he would tell him, Dr. Tu, I'm so-and-so. I have 7 millimeter acoustic schwannoma. I can hear, my hearing discrimination is 80%, and I would like you to do a middle fossa approach with me. So this is how educated sometimes the patients can be. I cannot tell you how that conversation went because it didn't go very well, but anyway, point in case is about how educated these patients are. So expectations are very important. We spend a lot of time talking to patients. Sometimes we spend more time talking to the patients about the surgery than the time it takes us to do the surgery. And this is not a complaint, actually. I think it's very well invested time, because then when you have a patient that is prepared and knows what to expect afterwards, I think that things are easier for everybody. And my job is definitely much easier. And then surgical team related options are very important. If you have a team that only consists of, let's say, a neurosurgeon only, that knows how to do only one thing, well, he will only do everything the same way and may not give the patient exactly what the patient needs. So, you know, having all the different options available is very, very important. And that's how I consider myself very blessed. So how do you decide to treat this? So you need to consider that we're dealing with a region that is a very small real estate. We're talking about the brainstem, which is pretty much as big as a let's say a golf ball, and tumors that sometimes are about the same size. And this area is very rich on very important structures. You not only have the brainstem, you have very important arteries that supply the brainstem and the brain. You have very important veins that drain the brainstem and the brain. You have your hearing organs. You have the facial nerve, which is very important, particularly for young female patients. We take special consideration when we decide our treatments because your facial expression is what defines you as a person. There's the trigeminal nerve. There's nerves that are related to the movement of the eyes. So all those things are in consideration. So we have very little space to manipulate and navigate safely so we can remove this tumor precisely. And so the surgical approaches rely on different windows that you can use through spaces that are virtually filled with cerebrospinal fluid through which you navigate. We call those cisterns, where you are navigating in little canyons or corridors between different structures, be it bone versus cerebellum, or cranial nerves and the cerebellum, cranial nerves and the brainstem. And so between these little corridors, this is how we design our strategies based on the location of the tumor. And then based on what the tumor is located, we can choose our approach. And this is a nice scheme that we worked on in the past, where you can access, if you would figure that the center of the tumor would be somewhere around here in this projection, the retrosigmoid approach, which is the one that I will talk to you about, is designed to be done in the back of the head, behind the ear, behind this structure, which is called the sigmoid sinus. That's why it's the retrosigmoid sinus. But then you will also hear the names of translabyrinthine approach, and you can see a picture of the labyrinth here, where you drill in front of the sigmoid sinus. So some people call it a pre-sigmoid approach, if you will. And then you access the tumor that way. And then there's the middle fossa approach, which this area is called the middle fossa, right at the temple, where you're seeing the auditory nerve from the top. Each one has different indications, and they are tailored to the tumor characteristics more and the hearing status of a patient, along with all the other patient factors that I mentioned before. So if we go back to the previous slide, where I show you that there were a lot of structures that we need to avoid, you would figure that there's pathways, for example, here, behind the sigmoid sinus that I just showed you, where you can access safely this area, the cerebellopontine angle, by navigating between the bone and the corridor that cerebellum generates for you. So draining a little bit of cerebrospinal fluid, you can safely expose this area without touching anything that is critical. And so that's the pathway that we use for the retrosigmoid approach. These are the others that you use for translab and middle fossa, but they're not the focus of our attention today. So focusing on this blue arrow, that is the trajectory, that is the vector that we use to access that area. And again, this one shows a little bit more of some of the modifications that you can do, but in general, the principle is the same. You use this virtual space that is between the cerebellum and the temporal bone to access this area, which is where you have your vestibular nerve, facial nerve, and auditory nerve. So this can be used, this is really the workhorse of acoustic neuroma surgery, because it can be used for any type of tumor. Actually, if the tumor is a big tumor, this is sometimes the only approach that you can use. If you have a small tumor, it works. If you want to do a hearing sparing or hearing preservation type of surgery, it works the majority of the times. And so that is why it is so popular, and that is why it's done by so many neurosurgeons. And sometimes they don't even involve an ENT, an otologist surgeon. I think it's a mistake, but this is my own philosophy. But you will see that in some places, neurosurgeons will dedicate to do this way. So it's an approach that's great. It's very versatile, but has a big limitation. And this is where your ENT otologist becomes your friend. This tumor gets into the internal auditory canal. And this is nicely seen here by transparency, but this is all bone. And so you need to have somebody who knows the anatomy of this area so they can work on this bone and expose the facial nerve and the internal auditory canal for you. And there's nobody better than an otologist to do that. And so to have somebody like Dr. Sami is extremely convenient. And so that is why for approaches like this, maybe I do the majority of the work time-wise in terms of hours spent under the microscope, but having somebody like Dr. Sami is fundamental. And conversely, for let's say a translabyrinthine approach, I may sit for several hours waiting and seeing how Dr. Sami drills on the mastoid bone and the temporal bone to expose the tumor and take some of the tumor while I work on the brainstem for just a little few minutes. And this is how we make our program, and this is how we can give the patients the solutions that they need. These are more schematics. I think that this depicts very well. This one shows this blade that you see here is a brain retractor, and that's pushing on the cerebellum. We have grown increasingly averse to the use of these retractors because they may help to expose the tumor very nicely, but they may help cause damage to the cerebellum by prolonged compression, or sometimes the blade indenting on the nervous system. So when we use it as little as possible. We rely on other maneuvers, working with anesthesia, working with drainage of cerebrospinal fluid. There's some surgical maneuvers in which we can drain some of that spinal fluid. Sometimes we do spinal taps to drain some of that fluid at the beginning in order to relax the brain and the structures to make the field more relaxed and do away from having to use retractors. There are specific cases when you have these massive tumors, like one of the scans that I show you, that you have to use it for a little bit until you start taking tumor. But then we tend to use more of the tumor, for more of the space that is generated by the tumor to access and to remove it. And a lot of the work that we do from inside the tumor. So we safely work inside the tumor. The only thing that you can damage is the tumor, which is what we want to do with the surgery. So this is how patients are positioned. Disclosure, I got criticized by my daughter when she saw this live by having the patient naked. I told her, no, Martina, patients are not naked in the operating room. This is just a schematic for teaching residents, but this is how patients are positioned. We try to keep them in a neutral position, just to align the spine. They're very comfortable, they're well padded. They are kept stable in the bed, so because sometimes we have to rotate the bed to get the proper angles. And this is the typical head holder that we use, so the head will not move during surgery. And this is the incision that we normally use. Could be either more of a straight line, usually it's more of a curved line behind the ear, right behind the hairline insertion. This is a view seen from the front. And again, this is the angle. You would see how you would approach if the surgeon is standing this way, straight down into this cerebellopontine angle, which is behind the ear. Keeping the shoulder away from your view, keeping the patient relaxed like he's hanging a pillow here. And this is a position where you can be comfortably set for several hours. Things that we learned through the years, sometimes when you're lying for a long time, you can develop some compression of some of the nerves in the extremities, and now we have avoided any problems related with that, because during surgery every patient gets some electrodes inserted on the 4 extremities as part of the neurophysiologic monitoring. And even if there's any kind of concern about a compression, whether if it's because of pressure or because of poor circulation, we get alerted and we can correct that in real time. So that's another safety measure that we use. Now going to the schematics, once you have your incision made, and I like this because this has a shadow of the sinuses. This is the transverse sinus, the sigmoid sinus will be here behind your ear. This is the type of window that we create. We make a very small window here, and this is what it would look like. This is part of the mastoid bone, which is an area that has a lot of air cells, looks like a honeycomb kind of structure, and that connects sometimes to the middle ear. So we pack this so there's no leakage of fluid in there through your ear. That's one of the things that we worry about when we do this surgery, is leakage of fluid, and we'll talk about in the closure. And then again, here's the outline of the sigmoid sinus, and this is how we open the dura, which is the membrane that keeps everything sealed tight for the cerebrospinal fluid. Underneath here, you see the outline of the cerebellum. And once you get there, and here you see the famous retractor that was just lambasting. Here's the sigmoid sinus in blue, okay? This is bone, and this is the area where the nerves come off, and this is the cerebellum. So when you have to come a little bit at an angle, creeping down along the bone, so you can get that cerebellopontine angle. Now, once you've gotten in there, that starts looking more like the first picture that I showed you, where you have the auditory nerve, there's the brainstem, there's the cerebellum that's been pushed, and that's the cerebellopontine angle. This is a case. Now, you need to bear with me because now the patient has been placed on the side. So now the ear is pointing up, but I like this because this one has the tumor with it. And so again, this is the sigmoid sinus, and this is bone, and this is the cerebellum, and the brainstem will be down here, and this is the tumor. And this is the four nerves that run together, 7 and 8, facial, auditory, superior, and inferior vestibular. And you see them as they hug. Sometimes it's not as clearly seen, and we have to fight a little bit with the tumor until we can see the nerves where they are, because the tumor tends to keep them away from us. Usually the nerves are displaced anteriorly. And while that is safe for the initial approach, we're a little bit on the dark side of the moon when we first approach the tumor, because we don't know where that nerve will be. Will it be immediately across the tumor? Will it be on the back of the tumor, on top of the tumor? Will it be in the bottom of the tumor? And that's where we use our special monitoring probes. So the instruments that we use, they're nerve stimulators, where we, as we resect the tumor, we're stimulating the structures just to be sure that we know where the nerve is, and we can map the nerve all the way from, and usually it's the facial nerve, the one that we worry the most about, because it's the thinnest and the most sensitive, and that's how we can map it and try to separate it from the tumor. But then once you find this, the principle is to open the tumor, you debulk it. That's how we call it, is emptying the tumor, leaving the capsule, so you can understand where the boundary of the tumor is. These tumors are usually well encapsulated. Luckily, they have a very nice boundary. And that's how we start separating it from the vestibular, the auditory and the facial nerve. Usually the vestibular nerve is one of the two vestibular nerves is the culprit. That's the one from which it attaches from, and that nerve usually gets sacrificed along with the tumor. And again, another important feature on how well you can do this, or how successful you can be, is how resectable the tumor is. And there are factors that go anywhere from the tumor adhesiveness. If the patient the tumor is very sticky, we want to be very careful, because that may put unduly traction on the nerves and cause some damage, particularly in the facial nerve. And also, I think I have another slide to show that, where if the tumor is very adherent, truly what option you have is to leave a little bit of capsule attached to it. Or the other situation is when you have a nerve. If you look at this nerve here as a single fiber, here you see how the individual small fibers that compose the tumor, they get splayed. like a rake. And those are really very, very fine filaments. And if you try to peel some of these tumor cells or this tumor capsule of those very fine filaments, you may inadvertently damage them because they become extremely friable. And then in that case, we sometimes leave a little bit of capsule attached to the tumor. We obviously leave as little tumor as possible to avoid any problem in the future. But the main goal that we have is to preserve nerve function. We don't go in on a commando operation to try to remove the tumor and be happy that we took the entire tumor out, and you leave your patient deaf and with a facial paralysis. That's devastating to us. This is towards the end of the resection. Here, luckily, the tumor has all come out. You see some of the nerve is a little bit stretched. Usually these nerves are more like a straight line. Here they're all stretched. And this is the internal auditory canal. This is where Dr. Sami comes in and has opened and resected the tumor out of this area, which is actually the harder area to deal with. Because that's where you have the facial nerve coming together with the auditory nerve. That's a very intricate anatomical area, which with some variability. So that's another reason to have a good neurotologist with you. And this is how we repair this bone that has, again, that honeycomb feature, where some of the cerebrospinal fluid can leak and cause you to have a leak either through the ear or through the nose from the middle ear. And so you see that we use some material, usually some waxy material, some bone wax. Sometimes we put a plug of muscle. We use some synthetic glue. You see how this is entirely sealed to try to keep it away from the fluid, keep it watertight. And the closure, we try to make it watertight on the dura. We're now working outside of the bone, where we use either fat, or we use some of the patient's own bone, or we use some synthetic material. Sometimes we use with titanium mesh. I run away from using titanium mesh because this area the skin is very thin and it's very sensitive, and I've seen problems with plates and mesh eroding through the skin. Or causing pain. So I try to stay away from that. And there are now some reabsorbable plates that can give you some buttressing while the patient heals, and then they get absorbed by the body. So this is a slide that shows all three main routes of approach and shows their advantages and disadvantages. I have two of this because they're both valid. The Retrosigmoid has the advantage of giving you a very wide exposure, so you can treat any tumor of any size, with the caveat that maybe tumors that go very far into the internal auditory canal may be a challenge because they are hidden inside the internal auditory canal. Hearing preservation is possible. You don't get as high rates as you would get with middle fossa, but there's a little bit of a bias with that, because with the middle fossa, we usually treat smaller tumors, which are easier to take out by the mere reason that they're small. You can early identify facial nerves, so that's a big plus. On the disadvantages, you have to sometimes retract the cerebellum. When you drill some of the bone inside the area where we have the cerebrospinal fluid, that may become an irritant and give you a pretty significant headache. After drilling, it generates an inflammatory reaction. We call that a chemical meningitis. Sometimes this confuses. It's not an infection, but it's all the inflammatory response of having all this bone dust. Even though we make every effort to limit the amount, there's always a little bit that trickles down. Again, in this other slide, similar situation, and the familiarity with most neurosurgeons is also a plus, but it's also a trap, because many neurosurgeons think that they're good at it and they can do it that way, and they miss on the opportunity of maybe doing something that is least aggressive or more appropriate for the patient. In terms of surgical results, this should be taken a little bit with a grain of salt, because all tumors are a little bit different, and there are factors that relate to the tumor itself and not so much to the approach that muddy a little bit the picture. But you can in the big majority of patients you can safely resect the tumors. When the tumor is completely removed, at least macroscopically, everything that can be seen, recurrence is extremely rare. I'm still trying to think of anybody in whom we were absolutely sure that we were able to take the tumor out and came back with the tumor years later. Maybe my children will see that. Hopefully they will not go into neurosurgery anyway, but that's a possibility. In patients that have subtotal removal, obviously the tumor control is not as effective because obviously you haven't taken the entire tumor out. However, in many patients, part of the strategy is to do a subtotal tumor removal, let's say followed by radiation. And again, different factors. Sometimes patients are adamant that they don't have a facial nerve paralysis. And we have had this situation with Dr. Sami many times, with Dr. Pensac, with Dr. Zuccarello, my partners here, where patients demand not to have a facial paralysis. And, fair enough, some of these are in charge of let's say, the fundraising or they're the head of a company. And truly, it has a stigma to have a facial weakness. It is a problem. We're very aware. So, sometimes subtotal resection is part of the strategy, or patients with NF2, where we're looking and seeing what the two tumors will do when they have bilateral neuromas. And really you want to preserve some nerve function, or patients that in whom you anticipate doing some procedure for hearing restoration, like cochlear implants or auditory brainstem implants. Sometimes a partial resection followed by radiosurgery is part of the strategy. Regrowth is possible. It's usually asymptomatic. It usually is controlled by radiation therapy if you have done an aggressive resection, because we have seen many patients that have gotten very very limited, very shy resections, where you take very small percentage of a tumor and then it's almost like doing nothing. In fact, sometimes I've seen that small sample of tumors are taken, and plus on top of that, the patient has had some sort of complication for that, and makes you wonder, how dangerous our decisions can be sometimes as a surgeon. Surgical results. Yeah, so these are the things that we consider, facial weakness, vestibular disturbance. Everything depends on tumor size, the characteristics. Obviously, the more experienced your team is, the better acquainted with what could go wrong happens. And that's how you learn to be appropriately aggressive with the tumors and prioritize the patient outcomes to what you're doing, because we are conscious that everything we do has lifelong implications. So we take this with great responsibility. Sometimes, these are things that are implied, but I think that they need to be said. We're very, very cognizant of the things that we can cause to patients. So that doesn't keep us from doing the right thing, but makes us appropriately aggressive, I think. And I think that only comes with years of practice. Well, that's another question that patients have. Hearing rarely improves after you resect the vestibular schwannoma. Hearing preservation means that we can keep at best what you had before your surgery, and that's something that also should be discussed. It's very important to discuss. I had many patients who thought that they would come to surgery thinking that their hearing would be back to normal, and that's not the case. Intraoperative facial monitoring has really made a big impact on how well we can resect this and how safely we can resect this. There's a number of surgical series across the world. The big majority of patients gets this removed. Normal facial movement is the big majority of patients with small tumors. 97% will have normal facial function. With large tumors, depending on the tumor size, because of all the stretching of the nerve and the degree of manipulation that you have to to undertake to remove the tumor, you have worse facial outcomes. That range is very wide, and I think that is useless when you come to discuss with your patient. And I think it's very individual. And again, there's different shades of facial paralysis, because when we talk about facial weakness, everybody thinks about the droopy face, and we talk about sometimes even a minimal eyelid opening difference, or maybe just a very small asymmetry in your facial creases, and that we consider part of our facial weakness classification. About 50% of patients would retain hearing. This, again, depending on the tumor size, depending on the approach. Usually the middle fossa gives you better outcomes, because we tend to treat, well, we only treat smaller tumors that way, and so that makes them more resectable and easier to preserve hearing. Yet the stakes are higher because you're expected to keep some sort of hearing. Complications, big complications, particularly with this approach, is cerebrospinal fluid leakage. When we open this membrane, we have to make a very watertight closure. We have to buttress that. Sometimes we use some sealants that are synthetic. There's some commercially available, not only sealants, but membranes that are used to protect that. Sometimes we buttress that with bone, sometimes with fat. Some patients, when they have some leakage, many times we just treat it with some oversewing with stitch. Sometimes we have to put a lumbar drain. The reason behind that would be to reduce the pressure across the seal, so there's no pulsating effect from the spinal fluid through that seal that you have created, and by diverting some of the fluid through the catheter in your back. Usually after a few days, if that's successful, you have avoided surgery. If that doesn't work after 3-4 days, you might as well just go back and repair that leakage, because it's not going to repair by itself, and now you have risk of having an infection because you have your cerebrospinal fluid exposed to skin flora. One common complication, or one common complaint, if you will, after the retrosigmoid craniotomy, since there's muscles that we have to cut here that hold your head, and also there is a nerve that comes right in the way where you're making your incision, which is the greater occipital nerve. Headaches are not uncommon, not only because of traction of the nerve or because some of the fibers are cut, but also entrapment into scar is not uncommon, and that could be affecting to many people their quality of life. So that's something that we also consider in the use of our retractors, in the use of our coagulation, on how we handle the tissues. But still, with all those precautions, we still see people with headaches that sometimes require some injections. I've had patients where I had to go in and actually do a surgery on the nerve to cut the nerve so they would not have pain from that nerve. And so that's something that we also consider, and this is also something that we also discuss with the patients. Mortality after this surgery, it's limited, very, 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 it's rare. Intraoperative mortality, I've never seen any for this surgery, and I hope I never do, touch on wood, in my life. It's usually from some sort of medical complication. The most common will be a deep venous thrombosis, patients that don't move much and they have clots in the legs and they go to the lungs in the postoperative period. So Dr. Sami is that has a taser where he uses patients just to walk every day after surgery, pretty much. He's a big proponent and the source of significant irritation for many patients for having them walk immediately after surgery, and he should be complimented for that, because I think that has kept our rates of deep venous thrombosis to very, very low numbers, almost non-existent, thank God. Infection is rare. Any procedure in the nervous system, likely we don't have high rates of infections. Hemorrhage also likely not that significant. Major neurologic complications rare. Paralysis, the only paralysis that I've seen is from the facial nerve. Haven't likely seen any significant problem with paralysis of a limb. I've seen patients who have had complications from other places, but likely we haven't seen that. We haven't had that experience, thank God. The adults more than 65, yes, they have increased risk for medical complications. I think that we have to change that or review that information because that's a little bit old. I think that when we see 65, maybe we should think more 75 because people nowadays live longer and healthier lives, and obviously we select well our patients. If you have renal failure or very significant cardiac problems, you have to be anticoagulated for another condition, might as well, unless you have significant brainstem compression. Those are patients that we send for radiation. Long-term symptom, headaches, like I said, with the retrosigmoid, very common. About half of the patients, they tend to resolve. They're more commonly associated with the retrosigmoid and tend to be more severe in women, and particularly in women who are small, very, very thin, small frame women tend to have more of these headaches. Other difficult to characterize problems are seen: memory problems, fatigue, depression. Sometimes there are other underlying conditions, and this is not just to excommunicate the surgery itself, but just the whole process of putting somebody through a life-changing procedure like a brain surgery may provoke some of these symptoms. Follow-up. There's just different follow-up strategies. Usually we follow this with imaging. For those who have hearing, Dr. Sami follows them with their audiograms and is attentive to see if there's any changes. As you know, as we all get older, we get more deaf. And so that's something that he follows up. There's different schemes. We usually scan patients every year for a certain period of time. 5 years or so, and then we start spacing them out. Some advocate for no scanning after 10 years. We tend to scan everybody for a longer period of time. In summary, there are about 90% of the CP angle tumors, usually hearing loss, some imbalance, tinnitus, maybe the symptoms. There are other cranial nerves. I mentioned about facial numbness. If you have a really big tumor, some patients have compression of the lower cranial nerves that are associated with swallowing or with your vocal cords. That would be rare. Has to be a massive tumor. And diagnosis is made with MRI. We tend to recommend patients with large tumors of younger age that are impaired and are good candidates for an operation. Earlier treatment rather than delay, even though they don't have main symptoms, but we consider the life expectancy in the context of their tumors. And so we tend to recommend more intervention. Observation for those that choose to go that route is certain that you will lose your hearing by 10 years, depending on how your tumor grows and tumor size. If you want to preserve hearing, obviously early treatment is encouraged. And the reason being, even though there's the trap that these tumors don't grow very fast, and you would assume that they remain the same size and your hearing will be the same, and that is false. That reality is not like that. We've seen tumors not change in size, yet hearing deteriorate with no changes in tumor size. And that's not related only to the tumor size. There are other circulatory factors that are related to the blood supply of the auditory nerve that have to do with that, we believe. And perhaps some inflammatory process that goes along with it. And so that's why we recommend early intervention. And the other thing is that is unpredictable. Both surgery and radiation are acceptable. They're comparable. If you look at that for small tumors, one has edges over the other. You know, if we want to consider tumor resection, obviously surgery has better chances. For facial nerve outcomes, radiation will have better results. For hearing preservation, we always argue with the radiation oncologists. They think they're right. We think they're right. They're comparable. And when you look at it, when you look at big numbers, the results tend to be comparable. So the choice is based on what you have available and what also your patient expects, and what you feel based on what the patient expectations and health conditions and tumor characteristics are. And I think I'm always going around the same concept, but truly we consider all those things when we decide our treatments. This is a little too much technicality. Obviously, when the tumor grows rapidly, you want to take it out. And NF2 is a very different, completely different population. And here, any decision that you make is extremely important because it will condition the decision that you will make next. So this is why we involve so many people in the treatment of this, anywhere from a radiologist, a geneticist, a neurologist, an oncologist, a radiation oncologist, an otologist, an audiologist, a neurosurgeon. All these people, those are the first that come to my head. But all those people have an important say, and the patient, of course, and their families, of course. All these have a very important say because every step that you take will condition the step that you will take next. So you want to be sure that by taking a certain step, you're not conditioning any future therapies that you will subject the patient to. And that is why it has gotten so complex, and we treat this as a very special population. Multidisciplinary team, that's the key to success. Anywhere from the person who coordinates your scan, the one who does your audiogram, to the one that takes your tumor, and the one that will take care of you after surgery is very important and is considered. And this is the group of people that you see over there. This is the minimum that you would expect. I have a couple of patients to show you, but I don't know if we have time.
We do have time, Dr. Andaluz. If you want to finish your last couple slides, then we'll open it up for questions.
Yeah, I just had two examples of retrosigmoid craniotomy that we have collected through the years. This patient is 53-year-old man. He had a known CP angle mass that was discovered during vertigo workup. And so he had radiations, you know, he has stereotactic radiation because that's what he chose. And still his hearing continued to get worse, and the tumor apparently got worse. Ignore what you see on the right side because it's just technical work for conveying to your neurologists and neurotologists. And see, here's his audiogram. This is what you will see on the normal ear. You see a drop. This is usually what you see. And Dr. Samik will criticize me for reading this audiogram because I don't know what I'm reading, or I pretend that I know what I'm doing. But the higher frequencies are decreased. You look at the word recognition on this ear is 0, while in the left you have perfect word recognition. And so this is somebody with a moderate to profound hearing loss and has no word understanding. So he has some kind of hearing that maybe somebody that I will tell Dr. Sami he can't hear anything that's useful, but maybe you can consider some kind of intervention to augment his hearing after a treatment. He's been radiated already. And this is, instead of seeing the nice round tumor like you see over there, you see this irregularly shaped, different intensity of tumor, of contrast enhancement. You see some of these dark spots here that usually is some dead tissue. That's usually an effect from the radiation. And then you also see all this involvement from the tumor. What you see here that is dark is the bone. And remember, if you're going to approach this way, you will have all this bone until you reach the end of a tumor. So this is a tumor that you can treat either way. You can treat either through a retrosigmoid approach, or you can treat through a translabyrinthine approach. So it may be valid for both approaches. Okay, so this is how it compresses the brainstem in the cerebellopontine angle. And so this patient eventually went and had a retrosigmoid approach. This second patient is 31, so it's a young man who has a tumor that was detected 2.5 years ago for headaches and facial numbness. So here again, facial numbness has nothing to do with the facial nerve, has to do with the trigeminal nerve. The trigeminal nerve, I'm sure many of you have heard about trigeminal neuralgia. It's the same nerve that relates to the sensation of the face on one side. And he had some kind of medical treatment there, IVF, for some hormonal stimulation. He was also treated with radiation. I don't know why I chose these two. I picked the two first that I found. But he had worsening hearing loss. The tumor kept on growing. And his hearing wasn't that bad. So he did have excellent word recognition, 96%. So this is a patient where you want to try to preserve some hearing. If you look at the scan, this is a big tumor. There's brainstem compression, there's cerebellum compression, there's some necrosis, some death of the tumor seen here on the scan as a result of the radiation. So he's got great hearing, or serviceable hearing. He's got a big tumor. You want to do everything possible to preserve hearing. By limitation of this size, he's not a good candidate for a middle fossa approach, so you cross that out. If you do a translabyrinthine approach, which you could for tumor characteristics, because it would fit the window that you get, you will make him deaf. So your only chance, if you want to preserve hearing, again, is a retrosigmoid approach. And here you see part of the sigmoid sinus. So you would approach this tumor this way and remove the tumor. Obviously, it's going to be, because it was radiated, sometimes they're very adherent. And so your risks of having a facial nerve weakness are higher. And one more, okay. So this presented emergently. This was a 47-year-old man that came, I think this one came emergently to the hospital with this massive tumor. So this is a very big tumor. This could become an emergency because it's compressing the fourth ventricle, which is an area where you have the pathways of your cerebrospinal fluid, and you can see that the ventricles are a little bit enlarged here as a result of that. So this is somebody that also would be treated through a retrosigmoid approach. Again, another schwannoma, and I think that was my last slide. Thank you.